I'm the Associate Director of the TMC Health Policy Institute, Stephen Linder, and it's my pleasure tonight to introduce our moderator for this panel on U.S. health policy methods, Jessica Mantel. She's an Associate Professor at the University of Houston Health Law Center and the Co-Director of the Health Law and Policy Institute.
Great, thank you. So welcome to what was supposed to be the second class of this series of lectures. Tonight I'm going to focus on giving you a framework for thinking about two important policy questions that come up all the time in healthcare. The first is, which level of government should address this issue, the federal government or the state government? And then second, what might be the best regulatory approach or regulatory tool to address the issue? So I'm going to start off with a lecture, the relevant concepts. I'm probably going to talk a little fast because I want to condense the lecture as much as I can so we can have as much time as possible for the panel discussion. What the panel discussion will focus on is applying the concepts that I will introduce in the lecture to Medicaid as our illustrative example. So as you all know, in the United States, our system of government is based on federalism. We have a centralized authority, the federal government, and then we have independent, autonomous, constituent jurisdictions, the 50 states. And under the US Constitution, both the federal government and the state governments have the authority to act in the healthcare policy arena. So we have this healthcare regulatory system that's this mishmash of federal laws and policies and state laws and policies. So if you're in healthcare policy and there's an issue that you want to address, you will start with this question of saying, should this issue be addressed by the federal government? Should it be left to the states? Or should it be a hybrid of both the federal government and state governments addressing this issue? And what I want to talk about now is that each level of government has its own advantages and disadvantages. So the factors I'm going to talk about, the advantages and disadvantages, fall into three categories. The first one, political philosophy, is getting at whether the federal government versus the states would better serve fundamental democratic values, such as representative government or equality. Then the second is looking at, if we give an issue to the states, will competition among the states lead them to do a better job addressing the issue, or would they do a worse job than if we gave the issue to the federal government? And then finally, we'll look at pragmatic considerations that might suggest that one level of government is just going to do a better job than another level of government. Okay. So we'll start with philosophical rationales for the state. So one important democratic value is having popular control over the public agenda. And many commentators think this favors state action. The reason for that is that states are obviously much smaller geographically than the entire United States. And so you tend to see greater uniformity among voter preferences at the state level. And so it's more likely then that state laws will be consistent with a higher percentage of citizens' preferences. Whereas at the federal government level, obviously there's greater diversity of viewpoints across the country. And it's easy to conceive that if the federal government were to act, maybe 51% of voters would be happy, but 49% might not be too happy. Also, because states are geographically smaller, it's easier for elected officials to learn voters' views, and so it's more likely then that the laws they adopt will be consistent with voter preferences. Second, we would expect to see a greater diversity of policies if we leave the issue to the state as opposed to the federal government, where there'll be a uniform national policy. And so therefore, it may be more likely that the state government will be more representative of citizens' views. Why? Because people can choose to live in the state where the public policies are more consistent with their views. So if they're conservative, they can choose to live in a conservative state, and if they're more liberal, they can choose to live in a more liberal state. Whereas at the national level, if you don't like a federal policy, in theory, you could move to another country, but obviously that's kind of hard to do, and very few people will do that. And then finally, if... We're getting closer to that. So, yeah, I know. I thought Canada might have gotten a little nervous. Anyways, and then finally, a factor that may favor states if you have a more libertarian view is that states tend to be their policies are less ambitious and on a smaller scale, in large part because they have fewer financial resources. So if you're a libertarian and you like small government, big government makes you nervous, you see that as a threat to individual liberty, you would favor state action over federal action because you would think federal action might be done on a grander scale and it's more threatening. On the other hand, there are philosophical rationales that favor federal action. Most people would say that people today have a stronger national identity than they used to. We have this shrinking country in the sense that we have a stronger national economy, and with advances in transportation and communication, it's easier to sort of get around from one place to another or work with people in other parts of the country. And so many people might think of themselves more as an American than have an identity based on their state. I'm not sure that's true in Texas, right? I think here in Texas, right, we're Texans. But in most parts of the country, I think people have a pretty strong national identity that might be stronger than their state identity. Okay. And so if you feel that way, have a stronger national identity, you may think that everyone, all Americans, should have the same rights and regulatory burdens. Okay. Relatedly is this idea of social justice, that certain rights just should not vary across state lines. If you think everyone has a right to health care, then you would favor federal action to ensure that all Americans have access to health care. And then another kind of related idea to that is that people think the federal government may do a better job protecting vulnerable citizens. Historically, states have been more discriminatory in their actions towards certain groups. You can sort of debate whether that's still true today. But one thing that is probably true today is that the sort of fiscal challenges that states face may hamper their ability to protect or promote the interests of more vulnerable populations. Now, second, looking at competition among states, what this is getting at is the extent to which, if we leave an issue to the states, competition among states for residents, particularly wealthy residents, and businesses, will that promote their doing a good job, right? Because they want to beat the state next to them. So the positive story there is that states will want to compete with one another to attract residents and businesses, and so they'll work really hard to be good performers in the public policy arena. On the other hand, sometimes competition among the states can be a bad thing. In wanting to attract businesses or wealthier residents, states may want to keep their taxes low. With lower tax revenues, they may not have the sufficient revenues to address certain problems. Or relatedly, they may be reluctant to give generous welfare benefits because they may fear that a lot of then lower income individuals will flood into their state, and then they'd have to raise taxes to meet all these individuals' needs. And states also may be hesitant to impose more stringent regulatory burdens, particularly on businesses, because they fear the businesses will then choose to set up shop in another state. Turning to pragmatic considerations, this is getting at whether there are attributes of the federal government or state government that may impact how effectively they can address an issue. So on the state side, a pro-state argument that you hear a lot about is that states can be laboratories of democracies. And what this means is that sometimes we don't know what's the most effective approach to a particular policy issue. So if we leave the issue to the states, different states can try different approaches, and we can see what works well and what doesn't work so well. Whereas at the federal government, it's less feasible to experiment and try different approaches. We tend to have a more uniform policy at the federal level. Second, there are some issues that are just inherently local. So healthcare, in many ways, is inherently local. People tend to go to healthcare providers in their community. Relatedly, problems can vary across regions or across states. So a one-size national policy may not fit everyone's needs. It may be better to have more local, state-based solutions that are tailored to the unique needs within that particular state. It also may be more politically feasible to have action at the state. There often is less diversity of viewpoints within a state, so it may be easier within a state to build consensus and support for some sort of political action. Okay. On the other hand, there are pragmatic considerations that favor action at the federal government. Some issues are inherently national. The benefits may accrue nationally across state lines, or we may have a collective action problem if we leave things to the states. So national defense is an issue where there's probably good reasons to leave it to the federal government, not the states. There also may be problems that impact citizens beyond a state's borders. So a contagious disease is unlikely to stay within a particular state. Drugs are sold nationally. It can be very costly and burdensome if manufacturers of drugs had to comply with 50 different state regulatory regimes. Second, the federal government has greater fiscal capacity, as I've alluded to. Interstate competition may push down taxes, the tax rate at the states. A lot of states are constrained by their state constitution with balanced budget amendments, so that forecloses their ability to do deficit spending. They also may have a fixed tax rate or may not have any income tax, like here in Texas, and that can hamper the state's ability to raise the revenue to address particular issues. The federal government, on the other hand, can do deficit spending. They can tax progressively, so it may be easier to raise tax revenue at the federal level to address certain issues that require a fair amount of fiscal spending. Third, if your goal is to redistribute resources from wealthier citizens to poorer citizens, there are advantages to having the federal government involved because they can take through taxes from wealthier citizens in one state and transfer some of that spending to poorer states. And that can allow for more equitable spending across state lines. And then finally, many people think the federal government may have just a greater institutional capacity that may be more effective or more efficient. So one way it may be more efficient is just economies of scale. It may be better to just have one government agency at the federal level addressing an issue than have 50 state agencies addressing that issue and duplicating each other's efforts. This is more controversial, but some people think that the federal bureaucracy is more competent. People that have studied that issue say it's a little unclear, but you do see greater variation among state agencies. Some have very large professional bureaucracies, others not so much. And then the federal government tends to pay its employees higher salaries than the states, so they may be able to attract individuals with more experience and talent. So once you decide which level of government should address an issue, then you need to decide, well, what's the best regulatory approach? So for example, if the state of Arizona says, we need to better address the mental health needs of our citizens, they could do that by directly providing mental health care to citizens, so they could employ mental health care professionals. They could contract with private mental health providers to better meet their citizens' needs. They could give patients vouchers that they could use for mental health services. They could just give grants to mental health providers. So there's just a range of options. And so the reading I asked you all to read today by Lester Salomon gives you a framework for thinking about which regulatory tool might be best. So on this slide, I have a list, and I kind of based it on the readings, of common tools. I've added a few to the list that were beyond what were in the readings. Some are self-explanatory, but let me just hit a few of them. So the direct provision is when the government entity is the provider of the good or service. So an example in healthcare would be the Veterans Administration or Indian Health Services. Contracting means the government contracts with private entities to deliver the good and service. Command and control standards, sometimes called social regulation, is getting at government laws or regulations that either restrict behavior or require behavior. So the HIPAA privacy rule would be an example of that. Economic incentives, it says, instead of mandating what behaviors people should or should not do, we're going to encourage them or discourage certain behaviors through financial incentives. So maybe we're going to give tax subsidies to those that engage in behaviors that we like. Information disclosure is when the government provides information to promote more informed decision-making by citizens. So provider report cards would be an example of that. And then economic regulation is setting of prices. So the state of Maryland, for example, sets its hospitals' payment rates. So Solomon gives us 5 criteria to help us choose which regulatory approach might be best for a particular problem. So first criteria is effectiveness. That asks, how likely is it that this particular regulatory tool will achieve our desired policy goal? So in my example about Arizona wanting to improve access to mental health care, you say, well, which regulatory tool is likely to best achieve that goal? Efficiency weighs the cost and benefits of this approach. So on the benefit side, we would look at both positive outcomes. You've actually have promoted or achieved your policy goal, but also any other positive byproducts. So in my example, if you increase access to mental health care, maybe there'll be less crime, or maybe there'll be greater worker productivity. So you'd include that on the benefit side as well. And then the cost side looks at the cost to the government, as well as cost to non-governmental entities and individuals. So that would be any sort of regulatory burden they might endure. So maybe you have a tool that would be highly effective, but also very costly. So it may not be appropriate given that, even though it's effective, that it may not be particularly efficient. Manageability gets at the ease or difficulty of operating the program or administering the program. So the more complex the regulatory tool, the harder it's going to be to manage the program or administer the program. And so why is that important? Because the harder it is to administer that program in practice, so the more moving parts there are, it's more likely something won't quite work as you hope, and that might impact the effectiveness, right? Your ability to achieve your policy goals. Solomon gives 2 meanings to equity. Equity first is getting at fairness considerations. Are the benefits and cost of this regulatory tool fairly evenly distributed? So under the Medicare program, really everyone is pretty equitable if you're at least over 65, maybe not so equitable as between people over 65 and under 65. It also gets at redistribution considerations. Sometimes our goal is to channel benefits to certain populations, maybe certain vulnerable populations. So we would ask, well, how successful will this tool be at channeling the benefits to the intended beneficiaries? And how likely might it be that there's a spillover and maybe it benefits people we didn't necessarily want to benefit? And then the final criteria, political feasibility, is asking us to evaluate how likely is it that there'll be political support or political opposition with respect to this particular regulatory tool. So you may have a regulatory approach that you've said, it will be highly effective, it's efficient, it's great, but wow, there's going to be a lot of political opposition. You may not want to then spend your time advocating for that regulatory tool. You may want to go for another regulatory tool where there'd be more political support. And then finally, political legitimacy is getting at the idea that some tools better facilitate political accountability. What that means, it may be easier for the public to perceive a link between the government action and the outcome. So if they can perceive a link that, wow, this government action actually worked really well or didn't work so well, they can then hold elected representatives accountable for either doing good things or not doing good things. Okay, so with that introduction, we're going to move on to the panel discussion. So let me briefly introduce the panelists. So first we have Ken Janda, who is president and CEO of Community Health Choice. That's a Houston-based managed care organization that focuses on the Medicaid population and other low-income individuals. He also sits on the board of the TMC Policy Institute. Next, we have my colleague Seth Chandler, who's also a professor at the University of Houston Law Center, and he's a nationally recognized expert in healthcare finance and health insurance. And then our final panelist is Tim Schauer. He's a vice president at Cornerstone Government Affairs. That's a bipartisan consulting firm that specializes in federal and state government relations, and he is an expert in Medicaid. Okay. So let me start by throwing a question to you all. I'm going to start with federalism. So as I think pretty much everyone here probably knows, Medicaid currently is a partnership between the federal government and the states. So each state operates its own Medicaid program, but they must do so within parameters set by the federal government. So the federal government has various rules related to who can be eligible for Medicaid, what has to be covered, whether you can charge a premium, and so on. There's also substantial federal financial support that goes to state Medicaid programs. So that's really, though, this hybrid approach is in contrast to Medicare, which is a federal-only program, right? The federal government operates Medicare. There really is no state involvement. And so some people have said they think Medicaid should follow the Medicare model, that Medicaid should just be a federal government program. So do you agree or disagree? Ken, you want to go first?
Okay. There's problems both ways. I hate to just start with a weasel answer like that, but there's a part of me that some days, because community health choice operates with, our contract with the state of Texas is for about $900 million every year, and we cover about 300,000 Medicaid eligible people. And so Texas has basically contracted out the Medicaid program, privatized it to big insurance companies like us. And so we have the great joy in the Medicaid program of trying to keep the state happy, but the state is also working with the federal government, and our 600-page contract that we have with the state of Texas and 2,000-page policy manual on top of the 600 pages is full of both federal regulations and state regulations about how we should operate the Medicaid program. And so this idea that there's rules that we have to follow because it's a joint state-federal program is problematic at times. And so there's certain days that I would like to say, we'd just be better off picking one or the other, right, and not having to deal with both. But the problem that I have, and it goes to one of the points that Jessica made a few minutes ago, is in the Medicaid program, frankly, the federal government is more sophisticated about how they think about it than the state of Texas is. And so there's a fair number of us that worry that if we were just in a Texas system, that it could be even worse than it is right now. So there's days when I'm like, yes, this should just be a federal program like Medicare. We know what the rules are. It would be easier. Then there's other days that I'm thinking, but what we do in Texas is a little bit different than what we do in other states, and we'd be better off with just give us a block grant and we'll do our own thing, right? And so today, at 5 minutes to 6 today, I would, I'm kind of in a federal camp today, but that might not be the same tomorrow.
Okay.
Yeah, let me say it's very interesting. I have the same bipolar issue that Ken does. His description was very interesting, and it echoes my own experience, which is that the fastest way I know of to get a headache is to try to read and understand the Medicaid statute. The cost that we have of our current hybrid system, which may be the worst possible combination, that is, we might be better either just leaving everything to the states or leaving everything to the federal government. What we have is a system where the federal government siphons out money out of the states, which makes it more difficult for the state to raise any money through taxes because it's all being siphoned through Washington, which has no accountability and is debt spending us into oblivion. They then write a zillion rules which fill up literally thousands of pages so that no one, someone who studies it for years like me or Jessica or Ken or Tim, nobody can understand it, resulting in their own internal operating procedures so that that value that you saw at the end of accountability is completely lost. And so the other question I would have is, why would we have a different allocation of federalism for people who are old, Medicare population, than people who are poor, which is essentially the Medicaid population? Why would that play out any differently? All the things that were on Jessica's very nice slides would seem to apply the same to both. And so I actually feel like we've made kind of the worst possible choice here. And I think probably either way one could say would be better. But I think that part of the mess that we have is because we really have failed to really think through carefully what virtues federalism serves here.
Yes. That was so the interesting angle I would take at this is Medicaid is not just a state and federal program. About a third of it comes from your local tax dollars too. So just to throw another little curveball at you, particularly if you live in Harris County, a big chunk of your funding that you pay in property taxes that you think goes to Harris Health to deliver care directly at Harris Health is only partially delivered at Harris Health. They use that money to seed a really goofy system of additional money that we draw down in a program called the Medicaid DSH program, which is an acronym for the Disproportionate Share Program for Hospitals, which is a mouthful, and we have way too many acronyms and names and complexity that we've added over the years. But the pragmatic side of me says, if you're panicked and you have an issue and you don't know how to deliver care to a lot of low-income people in a fast-growth state, and remember Texas has been a fast-growth state, you'll take money wherever you can get it. And so in the 80s, when things were going gangbusters and we were going, there were a lot of low-income people here that couldn't, it was bankrupting entire systems. And those systems, mostly the public health systems, went to the federal government and they said, okay, we can't get our legislature to fund healthcare for low-income people here, but we're spending a lot of our property tax dollars. So if you kind of think that those people are kind of Medicaid, would you match it and give us some money and help us out? And the Reagan administration, believe it or not, said, yeah, that actually sounds like a pretty good idea, because Cook County from Chicago was in here and LA County was here and New York and all these big urban areas are struggling with the same thing. Yeah, you know what, we'll just count that as kind of state dollars anyways, and we'll match that. So you got to remember that this wasn't a designed program that somebody woke up and said, we're going to design a Medicaid system that's logical. It was a political reality. How much could we do at which point, and how desperate was the system, and what duct tape and baling wire did we have to stick on it to keep it alive for another couple of years?
Well, I'm not quite as dystopian is that. I mean, part of it was that there was, in fact, when Medicaid started, there were local ordinances, state ordinances, the Texas Constitution that said the counties were responsible for indigent care, and there were county or city hospitals and stuff. And so there was a fear that the federal government had that if you just made it all a federal program, well, the counties and the states are already spending some of this money, so we'll supplement the money that they're already spending to create the Medicaid program. And so there was this idea that there was already money being spent at the local level.
I would almost have to go, the problem we have in this country is that we've never really committed to a model. Before you get into that, I mean, to me, there's 5 models of care that you can go with. I'm oversimplifying it down to 5. 1, it's all private insurance. You have no safety net whatsoever. If you've got private insurance, you get health care and you live. If you don't, you die. And quite frankly, the people who are in the White House right now would like to move to that model. They're not saying it because they're full of platitudes and thoughtless words and ad hominem attacks, but that's pretty much their model. That's what they want to do. Now, they're not going to come out and say that because it sounds kind of inhumane and kind of sick, but that's what it looks to me like they're advocating for.
And if you said that to old people, they would not vote for you, so you can't say that.
But the second model is this mixture of private insurance with a publicly funded safety net, which pretty much from the 40s through the 60s was about what we had when Ken's talking about. There was private insurance. It was kind of evolving private insurance, but you had county hospitals, you had charity hospitals, the churches were opening hospitals trying to do some things, and that was it. And if you could get care, great. Then with the Great Society program, we said, okay, well, wait a minute, maybe we should mix it. We'll do private insurance for the business community and for the people who can afford there, but there are some populations that can't, the elderly and the low income, so the Great Society said we'll go with somewhat of a hybrid and we'll add Medicare and Medicaid, but we don't really have enough money to fund it all, so we'll fund the Medicare. And again, this is factual political reality of what happened back in the 60s. They just said Medicare's only going to cost this much. We have that much. Medicaid, we really don't have enough money to do it all. So let's at least fund the Medicaid part that we can. We'll get it matched from the states and the locals, and we'll do these things. But that was the middle model they had. I would argue that we only modestly went after fixing the holes in that model with Obamacare, saying, you know what, we missed a lot of populations, we left it. And this chart that you got sitting in front of you kind of shows how they tried to take that third model and fill it in, right? And try to close all the gaps where they could, add in subsidized marketplace for an individual market. But that's really not a change in model. It's still a mixture of private insurance, public insurance, all this. Then the fourth model is what I would call publicly funded health insurance, right? Which is a Canadian model, single payer. You'll hear people talking about that. That's your fourth option. You still have private hospitals, private doctors, but they bill and they go through the process of utilizing private. And then the fifth model is, to a certain extent, the way the English did it, which is a full nationalized health system, full-on socialized doctors, everybody gets paid by the government, that's it. Those are your 5 models. And we've been meandering somewhere between model 2 and 3 as a country for 50 years, and right now we can't decide what we're doing. That's my biggest frustration is up until November of 2016, I had a pretty good idea that we were in the middle model, and how do we make that third model work? And right now, it's just horribly frustrating because I'm not sure where we're going. And if you ask Bernie, he wants to go all the way to the fourth model, but you ask again some of the folks that are in the current administration, they want to go all the way back to the first model. I don't know. I mean, that's, to me, you have to decide what model of care you want, and then you can use all sorts of regulatory structures. You can decide federal and state, but I don't even know what model we're pursuing right now in this country.
Others want to respond?
Well, I thought that where Tim was going to go, that the reason why Medicare is all federal dollars and the states is a mix, was that if you look at it, you know, part of the reason why we have public funding for health care for people is that it's really embarrassing to have like people that can't afford to pay for their own health care to like die in the street, and so we want to at least get them into a hospital and have them die out of sight and get some care. And so that old people, no matter where they live in the country, you know, are likely to die, right? But poor people, if they live in the South where it's warmer more of the time, you know, don't die in the snow as often. And so the northern states seem to be more willing to fund Medicaid than the southern states. And if you look at that even now with the Medicaid expansion of the Affordable Care Act, even though the federal government said to the state of Texas, we'll pay 100% of the cost of the Medicaid expansion, the people in the Texas coverage gap on the infamous, this is the TIM chart, by the way. This is the TIM, known in our company as the TIM chart. You know, we said, we don't care, even though you'll pay 100% of the cost, and then after 3 years, you'll pay 90% of the cost, we still don't want to do this. And we don't want to, and it's like, why would you not want to do this when we have this weird, cobbled together county, city, you know, charity process right now for certain low-income people? And I think the answer is that we still like, you know, they can make it on their own. I think it's the same way why we don't believe in the southern states as much in other kinds of social welfare type programs and welfare programs, or what we would now call TANF, temporary assistance for needy families, and those kind of things. And it's you know, to get back on my why I'm feeling today more like I don't like federalism is, you know, I don't think the needs of people for health care are different in Texas than they are in California or Washington or Massachusetts, right? I don't think that we need to have as much flexibility in terms of who's covered and how it's financed. I think there's still opportunity to have variation from state to state in terms of how you deliver those services, because frankly, how you deliver those services in Texas is perhaps different than some other states. And I would say how you deliver those services in Houston is different than how you deliver those services in Newton or Jasper County, which are only 90 miles away, because rural versus urban and those kind of things. So, I would like to see us be moving more in the direction of sort of saying, okay, how you deliver those services, the system of care may be a little bit different in different places, but how it's financed, what's covered, those kind of rules about eligibility, the fact that there's such complicated rules around eligibility for what, because in Texas, there's not a Medicaid program. There's a Medicaid program for pregnant women, which is different than the Medicaid program for newborns, which is different than the Medicaid program for children. I'm reading the columns here, right? Which is different than it is for people who are disabled, which is different than for parents of Medicaid children, which is different than for dually eligible Medicare and Medicaid people who live in nursing homes, and it's different if you live in a nursing home than if you live at home. It's a mess, and so cleaning up the mess would be good for me.
I think you've touched on kind of where I'd like to go next, right? Whereas I think no one I've not heard people say, take the federal government completely out of the picture, leave it to the states because of the funding issue, right? So if you left it completely to the states, you either have no Medicaid or not enough, right? With many populations left out. But we do have Republicans proposing a much smaller federal role, which is primarily a financial one, whether it be grants or or some sort of, most likely we're talking about block grants, but take away all that other stuff, some of what you were talking about, Ken, of this is, who's eligible, this is what you have to cover, and just say like, hey, states, you kind of, here's some money, you go figure it out. So
Let's talk
that's,
about that.
yeah.
It's a very odd idea in some respects. Why would we just give the money to the federal government so they can give it back to us? And the answer often comes back about taxing capacity, ability to engage in counter-cyclical spending because the federal government can print money, whereas the states cannot. But it's a very strange idea, and it rests on this notion, I think, that somehow we're willing to have ourselves taxed to pay Washington, but the states are unable to tax their citizens enough to actually pay for health care. And so it somehow depends on the fact that if it goes to Washington, we don't see it. It doesn't seem to come out of our pockets. And I think this is actually a very dangerous problem, and I think it's partly responsible for why we are heading. I mean, it doesn't sound like much when you just say 30 trillion. It's just a number. But it's an astronomical sum of money that we are putting on the backs of our kids. And right now, the debt service is not entirely unmanageable because interest rates are low. But what happens when interest rates, as they could, start to creep up and you get yourself into a Portuguese or a Greek debt spiral? And so the notion that it's fine for Washington to spend because they have taxing capacity, I think, is one that we should not just accept at face value. And I think we should be a little concerned about systems that just send money to Washington only to have it sent back.
But there's two different ways that you can kind of look at that. You could do like what the state does to the cities, which is basically have unfunded mandates. So you could have the federal government say, you must provide this, but not give any funds to do it, as often people at the county and at the school district level feel that the state does. So you could have that kind of roll downhill, or you could just say, yes, let's just make it the same everywhere, right? Because I guess I'm being that I'm feeling kind of centrist today, is that in many things there just isn't enough difference between the states anymore that we should have difference. And so I make the argument the other way, which is probably the better thing to do is get rid of all the 50 state governments and have one giant federal government right now because
Jefferson is rolling over in his grave.
I know he's rolling over in his grave, but it gets back to what is the additional value that we're getting out of having 50 different versions of Medicaid?
The regulatory tool that really hasn't been brought up and I think is pretty fundamental to health policy is the idea of risk management. And the weird thing about healthcare, and I say it's weird because when you actually really have a good conversation about healthcare and it doesn't matter which party, whoever, they're always trying to kind of squeeze the budget and we got to be able to cut money and it should be cut. But as soon as they or their loved ones need healthcare, they never ask about where do I get the cheapest doctor, where do I get the cheapest hospital. They're calling me saying, Tim, who's the best doctor in Houston that does X? Where's the best hospital? And can you put my loved one on the VIP list, which we don't do anymore. And by the way, 20 years ago we did. But I'm pretty sure we don't do that anymore unless you pay a ton of money to get there, which then you get on the VIP list.
I think you still can at MD Anderson.
Do you really?
Oh,
Okay.
yeah.
Anyways, point being is with risk management, the idea is there's a small group of us that are going to get sick and hurt every year. And it's going to cost a ton of money. But if you're lucky, you're not in that small group. That's literally all there is to it. Some people say, oh no, there's all these health indicators, and if you take care of yourself, you know what, my best friend was the healthiest guy you've ever met, and at 40 years old, he developed cancer, suffered horribly, spent a ton of money over the last 7 months of his life, and he died. He didn't do any of the stupid stuff that we did in college. If anybody should have died, it should have been me, not him. But he was super healthy, and guess what? His number came up and he died. And he spent a ton of money before he got there. So the idea of risk management to me is a really big thing. And so when I answer this question, I start thinking, what does the federal government do well? Well, they actually collect money pretty well in taxes, and they can manage really big pots of money. Well, if you set a threshold and you said, okay, instead of playing these games, let's just throw out current Medicare, throw out current Medicaid, and you said, we're going to underwrite a risk pool for every American man, woman, and child. Doesn't matter what the age is, but you don't get to tap the risk pool until you've cut through $10,000 in healthcare expenditures in a year. Okay, so the first $10,000, it's up to your state. You got to go talk to your state. How do you manage that first $10,000? Some states may say, you know, we're going to raise our own taxes and we're going to cover everybody. First $10,000, everybody's going to cover, right? Other states may say, well, we'll cover 5, the businesses can cover 3, and the individual can cover 2. Or they can just say, you know what, we don't want to do any of it, and every family can come up with the first 10, and nobody's going to go bankrupt for 10,000 because the hospitals will probably write it off. So go ahead and just don't pay that 10,000, and we'll just ask the federal government. There are some states that would do that, most of them in the South. But point being is you could come up with a model where all of a sudden the risk management would actually be handling those high expensive cases, and then you could start contracting with organizations that can get in there and hopefully work to reduce those costs and get the best care and all this kind of stuff. There's some ideas. I throw them out there because nobody's talking about this. Like I said, the only thing that's being talked about is ad hominem attacks, blatant just oversimplification. Let's just, vote no on Obamacare. It's horrible. We'll throw it all out. And I'm like, which part of it? It's a really complex bill. There's a lot of pieces. And now it turns out when they start undoing it, it's like a healthcare Jenga is the way I describe it. Because each time they pull out a piece, they're like, uh-oh, these other pieces were attached. Now they have to put it back up. So it's kind of a mess right now because I get back to we have no model of what we're trying to achieve. And if you don't know where you're going, any road will get you there. If you have a designation, if you know what model you're going to go to and you want to make it the most efficient and effective model, and there's agreement as a community, as a society, as the medical community could come up with a model and say, okay, here's what we want to do, then we could actually sit down and have a really good conversation about which regulatory tools do we do to get efficiency, effectiveness, cost containment, improve access, all those things that everybody in this room I know wants to do. But we're kind of meandering.
So as long as we're meandering, I got to go back to one comment that Seth made, because I share Seth's concern about that we're just spending ourselves into oblivion at the federal government. And so what the federal government decided to do in the December tax bill was to make it worse by cutting taxes and sort of say, let's see if we can pull off on a national level what Louisiana and Kansas have done a few years ago, which is drive themselves into bankruptcy by just, we're going to cut taxes and somehow magically there's going to be enough economic development that's going to make up for it. And so now Kansas has said, okay, we got to go back and raise taxes. I think Louisiana will be next at that. And so, it's this ongoing problem of we want more and more stuff from the federal government or the state government or the local government, but we want to not pay for it. And it's a fundamental problem.
I completely agree, and it is now, I think the Republicans have as much guilt on this for passing that tax cut bill without figuring out, okay, where are you going to cut the money then? What are you going to cut spending on? Because there's no one who thinks that there may be some economic growth that results from it, but there's no one who thinks that economic growth is going to be so large.
Trickle down.
No,
Come on, it's going to trickle down.
I believe in trickle down, but there's not enough.
But it's not.
The math does not work.
I do think that there are a few smart people. Speaker Ryan is an example. We're like, no, we really need to do this because that then forces us to cut entitlement spending. And this is the question is, really, you really think you're going to cut Medicare spending? Because Medicare spending is actually more than Medicaid. And you look at Medicaid, and of course, Medicaid did have a big jump in spending because of the Affordable Care Act of the states that did do the expansion. But it's like, this is going to be really hard to do. And so then if you move to a block grant, then you've essentially just sort of said, here, states, it's your problem. And frankly, I don't trust the state of Texas to say, okay, we'll make up the funds that the feds aren't giving us anymore, and it could be a mess.
I think it sounds like you're a believer in equity across state lines, right? Which would be kind of an argument for a bigger federal role, so that Texas isn't doing something different than Maryland and California and Iowa.
Well,
in terms of people's rights, like who's eligible and what they get. But what about this whole labs of democracy idea, right? That states can experiment. I mean, if you look at Medicaid programs across states, there's some really interesting innovation going on and big differences.
So can I?
Yeah.
I've always been a sucker for the lab metaphor, and I like the idea of sort of a Darwinian competition and seeing what's fittest, and I do believe in experimentation. However, I have to confess, I don't know that it's working so well, because in a lab experiment, it's a controlled experiment, and you can figure out maybe some causal relationships, or figure out that we can now take what we've learned in this one space and bring it to another. I'm not persuaded, to be honest, that we have that culture going on where we have learning and enough ideas of things that can be borrowed. And so we do have pluralism. We do have lots of different systems out there. But this notion, even as someone who likes the lab thing a lot, I don't really see it working in healthcare right now.
Well, here's part of my bipolar portion of this, is that in the Medicaid program, when it first started, 65, 66, and that, what is it? We got the right dates, Tim? Sounds about right.
Texas, we didn't start until 71. We held out as long as we could, but not as long as Arizona. Arizona held out till the 80s.
But anyway, the expenses started going up, and different states started looking at different ways to sort of change it. Because originally Medicaid was much like Medicare. It was like, it's a insurance program run by the state, but it's just you go to any doctor, any hospital you can find that'll accept your insurance, right? There wasn't really much of a management except trying to, as the costs went up, most of the states started saying, well, we'll pay the doctors less, we'll pay the hospitals less, and you get into this whole problem of being insufficient payer. But what Texas did was one of the very first states that said, well, let's try this, trying to put HMOs in place, and did what we now call Medicaid managed care. And Texas was one of the very first states in 96, 97 kind of time frame to really go in a big way. And so Texas was kind of a laboratory, an early laboratory that said, oh my gosh, this actually worked. And so in the state of Texas, on a per capita basis, Texas has had lower medical cost trend than any other sector anywhere, period. Less the rate of increase in medical costs in the Medicaid program per capita, per person, has been like 1 to 1.5% for 15 years. That's unheard of for, say, state employees, or for the Medicare program, or for commercial insurance, for employer-sponsored insurance. So something has worked very well, and now virtually every state has followed Texas's lead, and essentially the entire country is now outsourced the Medicaid program to companies like ours. And it's happened at various stages, but there's nothing much left of the Medicaid program anymore that isn't part of managed care. Now the question is, do you need to continue to experiment and have labs in different kind of ways? Is there something more that we can do, or do you just sort of say, okay, as the feds did, if you're going to do Medicaid managed care, now let's layer on an extra 600 pages of new regulation on how Medicaid managed care works?
We're about to test this out, because a number of states have started a work requirement for Medicaid, although it's a work requirement with a lot of exemptions. But there are various predictions about what will happen. Will people who really can't work be tossed off Medicaid and not receive medical care? Will it incentivize people who've been playing video games to now go work? There are different theories, and maybe we'll get some data. So I told you I was a little bit bipolar on this, but you should be aware that there are some I think that's a fairly important experiment that's going on, is to see what happens when you no longer have as strong a disincentive to join the workforce, because you may lose your Medicaid as a result.
Not to be argumentative on this one, but I think this is the goofiest thing in the world, because the way the Medicaid program works is people generally don't get on it until they're pregnant, if they're a woman, or they're sick if they're a kid. They're off the rolls, or on the rolls, or off the rolls. We're doing better with some of the kids. Ken's company does a great job, and some of the others are trying to keep people re-upping and staying on a program, which is where you see that primary care and preventive care and all that stuff really working. But fundamentally, if you really want to see work requirements really have some teeth, you got to get some guts and say, okay, if you're not working and you're on Medicaid, or you're not on Medicaid and you get sick or hurt and you end up in the emergency room, hospitals, go ahead and save that person's life, do everything you're going to do. By the way, it's federal law, you have to, but we're just not going to pay you. Because right now there's emergency Medicaid, and that you can retroactively get those people enrolled, and so you get people covered, and there's this kind of backwards game. You got to have the guts to make the hospitals eat that. Then all of a sudden the hospitals might be a little fired up and go, this doesn't work. Let's actually do things. The healthcare costs, let me just go back to the fundamental principle about healthcare. Nobody wakes up in the morning and goes, gosh, I want to go get some more healthcare. It's not a product or service that people opt into. I mean, it's something you get because you're sick or you're hurt. Now, granted, there's a few hypochondriacs. I will say there are a few hypochondriacs. But fundamentally, the big surgeries, the big diseases, the big things that cost you a lot are because you've been sick or hurt. You didn't choose them, and there's no market. There's no resale value afterwards. Like if I have an appendicitis right now, I didn't choose it. Nobody chose it, right? And they take it out. And they save my life, great. But if a week from now I decide, you know what, I'm not going to pay you guys. I canceled my insurance. Sorry, I didn't tell you that when I was there, but I canceled it, so I'm not going to pay you. They can't repo it. They can't put it back in. There's no resale value. They can't turn around and sell my inflamed appendix to anything. So they're stuck there without it. So they have to go to a government entity or a charity entity or somebody and say, who's going to pay for this appendix that came out? Oh, by the way, Tim's a renter in an apartment, has no assets that we can go after. So how do you use the basic market principles to collect from that? And that's the fundamental issue.
I have to stop you, because that is part. You know, this is the great thing. Everybody now is very good at taking a partial truth and then spinning it into other things. But if for somebody who sees this every day, the fastest growing part of the costs that we have is in prescription drug spend, which isn't about living and dying. Now, we did have a big jump a couple years ago when hepatitis C drugs came out, and it's like, you know what, Sovaldi and Arboni and those guys, I mean, they work, right? And it's like, okay, we spend a lot on that, but it works. But now what we're seeing is apparently everybody needs to have Humira or Enbrel because it's good for your arthritis, and it's all, and these are very expensive drugs, and you sort of say, okay, how much more improvement in your life? You're not going to die by not taking your Enbrel, but you may feel better, you may be able to walk better, you may not be as and it's more about a quality of life issues. And so, you know, there's another argument about all this, which says, and this is kind of, some of my friends at Deloitte say this, it's like, why are we complaining so much about how much healthcare costs? This is what people want. This is like, they want this more than they want more iPhones and fancier cars to drive. They actually want to be able to feel better, and they want to,
If they're
sort
in
of the
pain or they're sick. I mean, nobody. If I'm perfectly healthy, I'm not going to call up and go, "Hey, I want to take some Humira."
Well, I mean, but we all have aches and pains. You know, my knee hurts me right now, and it's like, how much does it hurt me before I decide to go find something to take care of it, right? And so we do, you know, it's not just the sick and hurt. Is my point.
Also, we have drug developments and device developments that if we had a more private market and we didn't have a government, and now I'll put on a trough there, those would not exist because people would not be able to afford them. And once you have it, once it's there, everybody wants it. And so one of, I think, the interesting issues is the extent to which our open-ended government funding of healthcare has stimulated devices and drugs that are often of marginal benefit, but that are nonetheless expensive. And why does Harvoni and Solvaldi cost as much as they do? It's because they believe that's what they can actually extract out of the government. That's basically the limiting factor. And so that's a problem.
Well, we also allow direct-to-consumer marketing, which we're one of two countries in the entire
but now
world.
this guy wanted to abolish the 10th Amendment a few minutes ago. You want to abolish the First Amendment just now, and so before we...
Whoa. How does limiting commercials for drugs...
Read Central Hudson. Supreme Court has said that commercial speech is free speech, and you ought to think really hard before you want to have some government agent decide what falls on the commercial side and what falls on the political and other side. And I think we ought to be really careful.
I'm going to go with Seth and the First Amendment, but what we need is more transparency of the costs and more people having skin in the game to sort of understand, and then let everybody advertise.
And I don't like those direct-to-consumer ads.
We'll let Jessica ask.
Well, I think I see some hands in the audience, so why don't we turn things over for some audience questions?
Yes, hi. I have a quick question. Do you anticipate, given the complexities and intricacies of healthcare today, do you anticipate that the new company that Warren Buffett with Jamie Dimon are forming, do you really think that they're going to be able to make a dent on the cost of healthcare?
Maybe. It depends on what they try to do. So Warren Buffett actually owns a number of big insurance companies, like Geico is part of Berkshire Hathaway, and they own some big reinsurance companies. So if they bring to bear people that really understand what Tim was talking about earlier about risk and risk management, then that's really good. On the other hand, if what they think is that, oh, it's just a technology thing, and if people all had a different app on their iPhone and could dial up an Amazon kind of thing or a banking app, then no. On the other hand, on the technology side of it, if they can apply an Amazon type approach to people shopping for healthcare, and there's transparency of how much Enbrel costs versus, I can't think of the name of the older drug, but it's the difference is like $100 a month versus $5,000 a month, and you can ask, okay, how much better does your arthritis feel at $5,000 a month versus $100 a month? Maybe that makes a difference so that we can actually talk about what's really cost effective and comparative effectiveness of different things. It's hard though. I mean, I've been doing this for 40 years and it's just really, really hard. I wish them the best. I love disruptors. I love laboratory. This is another laboratory, but I'm not going to put all my money on them.
I'm sorry, go ahead.
I have a question about on the jobs requirement thing, because you know, those of us with white hair and have been working on Medicaid for decades, we moved away from Medicaid being based on a welfare-related concept of only for, you know, coverage only for certain part of the population that was incapable of working for a variety of reasons, and therefore we'd help them out, to, and I live this, starting in the late 80s, 90s, 2000s, it's been going on for 35 years, all the way up through ACA now. We have been expanding Medicaid coverage under a principle of the United States not committing to universal coverage, but committing to basic coverage for everyone, particularly vulnerable populations, vulnerable because of their inability to work due to disability, pregnancy, being a child, being retired, whatever. Okay. So I know the Trump administration seems to be supporting this work requirement stuff and introducing work requirements to Medicaid eligibility, and I do believe 5 or 6 states have got waivers in, and I believe Arkansas was approved just yesterday or today. I just wanted to know, Seth, if, you know, I see the practicality, welfare dependency and all that dependency, and the cost, but we decided, I believe, you know, a long time ago that we didn't care about that with Medicaid.
You
we
decided
were
that.
do,
The people who are in charge don't agree with it. That is, I think there's a fundamental ideological divide where they do not agree with what was, you're describing reality correctly.
I know.
But they do not agree ideologically.
I know, but they will be, but there are many of us who are ideologically, you know, spend our whole careers working on
you just lost an election.
basic minimum coverage for the United States population, right?
Right.
Now, we're going to have a hard time with that, and I can see Texas coming up with a waiver proposal very soon that's going to have those work requirements in there. It's going to create
here's my
a wonderful debate.
Yeah, but here's my pragmatic view of this, is that both sides are wrong. Okay, and in this way is like the people, and I'll put my side in the camp of this is a stupid idea, because as Tim said earlier, it would require us to say, if you are capable of working and you choose not to work, then we're going to let you die in the street. And I think in the end, not even the people that say there's work requirements actually believe that. What they want is somebody else to pay for it, but they won't articulate who that is that they want to pay for it. So it's like there's no good reason to do this. On the other hand, I do think that any of the states that try to do this are going to find out that the administrative problems of doing this and how many people you actually take off the rolls is so minuscule that you have to say this was a dumb idea. So I would suggest for the state of Texas is I would take today a work requirement in exchange for expanding coverage. Because I would say, okay, we're going to expand it to everybody, but you know, for those of you, you know, Dr. Schwertner, other people that have said publicly, we don't want able-bodied adults to have Medicaid, they should just go out and get a job. It's like, fine, let's not do them. If you can find those people, but let's cover the people with chronic mental health illness. Let's find the people that are, you know, and we're going to cover pregnant women, you know, even after their birth while they're still taking care of her. When you read through all what CMS has approved in terms of all the exceptions, we would still cover 95% of the people, and frankly, I'll take the 95% and let's see what we're going to do with those 5%.
On Tim's chart, it's only, as I understand, these states are only doing it with parents and childless adults, not the kids, not the pregnant women, not the disabled population.
Right. That's correct.
Which makes some sense, but what I'm saying is still, Medicaid, we fought this battle decades ago. We've decided work requirements should not be a part of it. It's about coverage for health care for the population with the deep pockets of the federal government.
Yeah, elections matter, and since the Tea Party in 2010 and now the 1611 election, we have a bunch of people that seem to feel differently
Could
about
I
it.
add one other point, which is you should not lose total hope, because you may have courts on your side. That is, the legality of this change is a fair question. In order to get one of these 1115 waivers, which is what these states are using in order to impose these work requirements, they're going to have to show some court, when some person complains about it, that this waiver and requirement of work was consistent with the overall purposes of the Medicaid statute. And they are not going to file that lawsuit in some conservative jurisdiction. They're going to file that lawsuit before, the Northern District of California or someplace in New York, and they may find a sympathetic judge who's not fond of, Donald Trump's tweets, and they may well prevail, at least for some time. So before
lawyers do that?
Yes, they do. So before you, whether ideologically you're right or wrong or whatever, you should not lose hope.
But I'd like to add, to me, if you're going to say that the low-income people have to have a job in order to get coverage, then I would say if a mandate's good, right? Then how about all the employers have to provide coverage for their employees? Well,
No,
that's
we
that.
don't want that.
Oh no, you don't want that.
No, we don't want that. That's
but
a
if
terrible
jobs are how
Terrible
you get
idea.
coverage,
Terrible idea to have the whole original sin in American healthcare was to tie one's health insurance to the labor market, to a badly functioning labor market, and we should not be reinforcing that. That was one of the worst decisions of Obamacare, and it's one of the things that should go.
Well, except that and Obamacare actually had the ability to get employers out of it. And the combination of the individual mandate and the market for individual insurance without pre-existing conditions and guaranteed renewability had the possibility, had we thought about it correctly, to get employers out of it. Because what now we actually, by the combination of the ACA and what was passed in the 21st Century Cures bill, which was to allow small employers to do a health reimbursement account where they could simply have a defined contribution. Here, I'll pay this much, and you go buy an individual policy. That could have been set up in the ACA. That would have been in Ken's version of ACA 2.0, which would have led us out of the employer-sponsored insurance to employers simply being a defined contribution.
Yes, but why should they have been required to put
Well,
any money towards that rather than just paying their employees more in wages?
Yeah, I'm sorry. I would say it's a voluntary defined contribution, just like
okay.
retirement
That's fine.
is a defined contribution now is voluntary. And then we would sort of see how important this is to people. But that didn't happen.
Yes, I have a question. First of all, let me thank you all for your comments. This has been very informative, and I appreciate it.
Yeah, three non-opinionated guys up here.
Exactly. Let me preface this question by saying I do believe in free enterprise and the profit motive. However, my question is, in the United States, do we not handicap ourselves to some degree in delivering the majority of our health care through private insurance companies, which do have to make a profit? And I don't know what that.
Well, I think nonprofit health insurance companies that are created by public hospital districts are a brilliant idea to address that issue, because any surplus that we have is then put back into the community to expand programs for everyone. But that said, every place in the American healthcare system is a profit motive. There's a profit motive for the drug manufacturers, and there's a profit motive for the doctors, and there's a profit motive for the hospitals, and there's a profit motive for whoever else I missed, right? So to just say that the problem is a profit motive for the insurance companies you're right. You could take 3% out of the cost by taking the insurance company's profit motive out of it. The administrative expense would still be there if you wanted to have a pluralist kind of system like we have, and you wouldn't take the profit motive out of Gilead or some of the other drug manufacturers. If we want to take the profit motive out, we got to take it out in lots of other places as well. And so that gets you much closer to Tim's 4 or 5 on his sort of range of different things. And I don't think as a country we're ready to go past 3.
Thank you.
But the nonprofit for-profit issue is one that you'll hear several kind of policy wonk type people argue that when health insurance in the hospitals and everyone had a much more community oriented, it was a mutual insurance and the community owned the hospital, and so whatever profits were made stayed there in that community, that you could argue that communities were better off for it, whereas when everybody's trying to feed Wall Street, when everybody's trying to turn around and get such returns that you don't put the routine capital into the local hospitals if you're a for-profit hospital, the for-profit surgery centers are doing all sorts of creative, the latest thing of these emergency rooms, I'm probably upsetting somebody here, but these standalone emergency rooms that are for-profit standalone emergency rooms that have figured out all sorts of real quirky ways of billing. Dr. Ho over at Rice wrote a great paper about basically saying that they're glorified urgent care centers, but if they bill like a standalone emergency center, they can make unbelievable amounts of money in a for-profit world. So to Ken's point, those are some really good policy discussions that we need to be having. And again, quite frankly, my biggest frustration with what's happened in the last 10 years is I used to have these type of policy discussions when I was a staffer in the 90s over in Austin, and when I started going up to Congress, the congressional staffers had these types of good conversations. They let their bosses kind of throw the political mud above, but everybody was having some really good policy discussions. And now what I've seen happen is instead of having good policy discussions with the people who are actually trying to make a system work, they've melted down into this, oh, you're just a crazy tree hugger, or oh, you're just a Tea Party guy, or oh, you're this, and they don't even actually have a conversation anymore about that pragmatic.
It's about winning without ever thinking about why you want to win.
Yeah.
So maybe we could, in the laboratories of democracy, maybe Texas could develop a model that says that all the health insurance companies have to be nonprofit, community-based
I'd vote for
plans, and get the big national guys that I used to work for out of the state completely. And let's also take the for-profit emergency rooms out and the for-profit drug companies, and we'll have a nonprofit drug company to manufacture generics only. And we'll just forego new brand names, and we'll only use generics because most of what we need is probably available generic. That would be a great experiment to do something different.
But final bullet point: political feasibility.
Well, it does violate that point. Yes, I would say that would be a
maybe
but a
otherwise
challenge.
be a great regulatory tool.
But maybe but maybe not in Texas. But it might be feasible in Massachusetts or Vermont or someplace. So.
Yeah.
I didn't mean to pick on the insurance companies, but you could look at a lot of other profit motives.
Yeah.
Doctor-owned hospitals.
Well, I'm just particularly sensitive about that part. I do run an insurance company, so it's like.
Hi. I think the discussion has focused a lot on the costs of providing health care, but obviously so many other factors go into health. So I was wondering if you could comment on what role, if any, either the federal or state government could play in encouraging health over, health care.
Right. So that's an incredibly important point. It should not have been our side point, and it shouldn't be treated as some question. It's an incredibly important point. And we have a number of policies which seem to sabotage health. Our agricultural policy, I think, is not designed to bring about food prices and differential food prices that encourage healthy choices. We have development policies that don't seem to encourage development of parks and places where people can stay healthy. I often wonder if we wouldn't do better to spend, instead of spending all that money on health care, is to just spend money on buying parks, and sidewalks so that people can walk safely, and frankly, in police, so that in poor neighborhoods people can go out and feel safe engaging in daily activities of life. Or police because people are being, a leading cause of death among a lot of communities is homicide. Or injuries from violence and domestic violence. And so your question is very, very well taken. And there are things that make sense for government to provide.
But what's really encouraging to me, though, is that even the state of Texas is asking these questions right now, because this whole thing about these social determinants of health is like a big buzzword throughout the whole, or buzz phrase throughout the country right now. And so we're, like many other safety net health plans like ours, are actively looking at what are these things that we should be doing, and how do we, so last week, one of our VPs and me met with Brian Green, who runs the Houston Food Bank. It's like, okay, how do we collaborate between what the food bank is doing and what a health plan is doing to change these things? And if this program had not been iced out in January, Elena Marks would be here with us, who is like the best person, certainly in the Houston metro area and maybe in the entire state, about thinking about this kind of stuff. And so when we were talking today, we had actually a meeting with the state Medicaid director and her staff, and that was one of the questions they asked us: what are you doing about this? And so we put it back to them. It's like, we are willing and able to, we have all these partners in the community. We could do something about this, but we can't do it for free, right? So how much, incremental are you going to allow us to either keep in surplus, which the state pulls back after we make a certain amount of surplus? Would you let us keep? Or how could we finance some more structured pilots around this, and how much of it would make sense? I do have to say, though, that the payback in terms of the return on investment in investing in things that might long-term improve people's health may not actually save money. And it's certainly not going to save money short-term, because in the short term, it's the big catastrophic stuff that is the big dollars, right? It's not, the cost of preventing somebody from becoming a diabetic this year isn't, it doesn't save us as an insurance company money. So it's hard to invest in things that might have a 10-year, 15-year return. And even then, that just might mean that person gets sick from something else
Would you have a
instead.
problem with if others had to do it as well, with making the default period for health insurance instead of 1 year, 5 years, 10 years, so that you did have correct incentives to look at people's long-term behavior?
That would be okay with us. We're actually trying to approach it from not quite as prescriptive of approach, to sort of say, if we had more people in the country making individual decisions about which health insurance company they chose to be with, and if we had stability in the marketplace around rates that have nothing to do with our ability to manage, but crazy stuff that the federal government is doing right now, that people would voluntarily stay with their health insurance plan much longer, much like there's much less churn in the automobile and homeowners insurance business in terms of how often people change companies. Is much less than it is in health insurance, because many of us change health insurance companies because our employer decided for us, or because of other things that are going on with rates that have nothing to do with the service and the network and stuff. So I would take 5 years, but I think we have the ability within the current system to get more people to stay longer, and that would, in fact, be good.
And if I could jump in on kind of the policy and legislative approach, and over my 25 years of working with the Texas legislature, I can tell you there's been some great things that we've done. And for folks that have been involved with congressional action for the last 50 years, I mean, part of the reason we live healthier now is because we've cleaned up the air and we've cleaned up the water. And a lot of that was because the government did it. Private sector responded begrudgingly, and they still hate it. And as a matter of fact, our wonderful administration right now is trying to undo some of those regulations and allow polluters to stick stuff back in the water that kills people, right? But there's also been some really cool things we've done in the legislature. No, that's federal. Okay, you're right. But at the state legislature, I worked with a whole bunch of doctors and very passionate young people in the early 90s to get a motorcycle helmet law passed. And that was great. And then a bunch of motorcycle guys, one of them a Vietnam vet whose nickname was Sputnik, started protesting all this, saying that it was a nanny state approach to force everyone to wear a helmet. And so you have to take that off, and you couldn't do that, and so they watered down that language over the years. We worked on some really good anti-tobacco legislation. I mean, it took, what, 70 years to actually prove that tobacco was bad for you? And we finally, in Texas in the mid-90s, reduced youth access to tobacco. So there's been some great public health bills that we've worked on over the years that have done some really good things. Here in Houston, the Parks by You bond initiative that passed. Granted, the plan was initially drawn up in 1911, and it only took us 100 years to get it passed. But, you know, I love the Winston Churchill quote, you can count on Americans to do what's right after we've tried everything else first. And to a certain extent, we've been doing a lot of things where we've tried other things. But, you know, if you're passionate about something that shows improvement in people's health, you can usually get an audience. Now, the first time you try it, you may not make as much inroads. One of the passionate things I'm fired up about is I work with a group on childhood obesity. And one of my biggest things is I can't believe little kids don't get recess anymore. I would have gone nuts when I was a kid if I didn't get recess. I mean, I'm getting bored right now sitting up here, and I'm the one talking. And it's just, I got to get outside and play every once in a while. I'm still that way, right? And we've taken away recess from these kids. You need to have a brain break, particularly when you're little, about every hour and a half, 45 minutes. Well, several years ago, in the name of improving academic performance and improving test scores and everything, we gave every school district the right to kind of set their own recess policy with no guidance whatsoever, and almost all of them have gotten rid of all the recesses with the exception of a little 15-minute break after lunch. That's crazy. And so I worked on a bill to try to encourage a study. I wasn't even going to mandate anything. It was just going to study the impact of recess in areas where it was good so that we could actually build some momentum to encourage schools to embrace a small recess, particularly for elementary schools. And I was called a socialist and a communist, and that this was over aggressive, and it was a nanny state approach, and just let the local control handle it. So we'll go back next time, and we'll keep fighting for it because I'm passionate about it, and I think it's one of those things that we need. It's good for kids' mental health, particularly kids like me that had to go out, and you know, it's important. It's important for their physical health. We got to get out there and play. Social health, you learn how to interact with each other. Unsupervised recess.
Exactly, without the phone.
Yeah.
But it won't lower your insurance premiums this year. So, sorry.
So, I mean, just
Okay.
bringing it back to the theme about regulatory tools. I mean, so these are all sorts of examples of command and control standards. You have to wear a helmet, you have to have recess, and it really triggers, go into the next slide, right? The political issue, right? Because it's nanny state, invading my autonomy. And so one thing that, back slide now, that has gotten a lot of attention in the healthcare world as an alternative to command and control is economic incentives. So I want to bring it back to quality. I know you were asking more about health, and we were talking a lot about social determinants of health. But there's the narrow sense of quality of ensuring that the medical care is of high quality. And I think there's a lot of it used to be that the way we ensured that, at least the way the Medicaid, I'm going to bring it back to Medicaid now, that the way the Medicaid program did that, and Medicare as well, was there were regulations, right? Like you must do this, and you know your nursing home has to have this many people on your staff and follow these requirements. And now we've shifted away a little bit, and this is a little bit of the labs of democracy idea, is a lot of states are experimenting with economic incentives. We're going to pay you for quality of care rather than paying everyone the same, regardless of how good a job you're doing. So what do you think about that as a regulatory tool? I'm bringing this back now.
There's
So
actually
you're talking about MACRA? I mean, is that what you're from?
Yeah, although,
Well,
you know, in
in-
Medicaid, I mean, I'll keep it Medicaid. I mean, you see a lot of states experimenting with these economic incentives, financial incentives to try to promote quality by rewarding good quality care and penalizing bad quality care.
So that was actually another part of the conversation today that we had with the Medicaid department was what are we doing to move to value-based purchasing for services, and the answer is we're not moving as fast as we would like to because all of the bureaucratic rules that exist out there in terms of stark laws for doctors and everything else that's out there, HIPAA, all these things all create additional regulatory barriers that make it very difficult to change away from the fee-for-service system. So we built a fee-for-service system, and then we started building things to try to hold back the fee-for-service system from running over us, because the more you do, the more you make, kind of thing. And so we now have built all these things that now make it very, very difficult to change to a new system. So doctors and hospitals are very resistant to change, because it changes all their information systems, all the way the electronic health record systems works, all their billing systems. Everything is built around a fee-for-service model. And so there's tremendous resistance in the provider community to do this, not because they don't understand that it's a good idea, but it's like, it's going to be very expensive and very hard and very different. It changes so many people's jobs from what they are right now, that it's harder to do than it should be. But I think it's still a very necessary thing. We have to move away from just the more you do, the more you make health business, and instead tie it to outcomes. The state has shown in the Medicaid program that you can be very effective in certain kinds of things. So the state incentivizes the health plans to improve HEDIS results for immunizations, prenatal care, postpartum care, a bunch of kind of standard kind of HEDIS measures. And now they're not absolute outcome measures, they're more process measures, but they're processes that we think actually lead to better outcomes. And by simply sort of saying to us, we're going to claw back $25 million if you don't meet these measures, guess what? We spend $1 million to make sure we don't get 25 million clawed back, right? And so we've had tremendous improvements in the state of Texas. What people miss in the Medicaid program in the state of Texas is that, well, Chuck knows this because he did the research. The results for pediatric child exams, stuff like that, are just as good in the Medicaid program as they are in commercial insurance. I mean, it's not a second-class kind of system at all anymore. The quality of care and C-section rates and low birth babies and stuff in the Medicaid system, even with low-income people who have other challenges that causes poor results, is improving very rapidly, and many of these measures are very close to other parts of the business. So putting financial incentives to do something besides just reducing how much we pay, I think can be very effective, but boy, it's hard. And most of that is really around the computer systems that people have invested in, and then the regulatory burden that we've had. And so that's every once in a while, when I do think we shouldn't have a federal system, it's like, no, just give us our per capita allotment, not a block grant, a per capita allotment, because in a growth state you want money for every new person that comes along, and let us pull off some of these regulatory burdens that we have right now. It could be very effective.
Yeah. Beyond even the implementation issues, which are very important, there's a conceptual issue, which is measuring quality through numbers, and I love numbers, is very, very difficult, and it is subject to gaming. That is the fact that two things are statistically correlated, and therefore, we say you should do the following, doesn't mean that there's causation. And so you then do the following, but nothing actually improves. Or the doctor knows that they need to check the box now, and so they check the box rather than actually accomplishing anything. And so you're seeing, I think, a fair amount of pushback against macro, which is one of the systems that's in. They keep saying it's going to be in place, and it keeps being delayed as people push back. I would love to see fee-for-service is not a very good model, but I will say that even with all of our modern technology and the like, actually measuring the quality of what goes on in that doctor-patient interaction is a very difficult thing, just as it would be. Many of you may be professionals. Imagine, how do you have a metric for how well I teach the 10th Amendment or something? It's a very difficult thing to measure.
So it is, and it will continue to be, because as science evolves and the technology evolves, there are breakthroughs that all of a sudden the value measure that we did 2 years ago isn't the value anymore. We need to be moving it. So it needs to be a flexible system, whatever we design. But I will tell you that as when I was working at Memorial Hermann and they implemented some of the emergency room procedures for heart attack, people who presented with the symptoms of a heart attack. Once they implemented a bunch of those quality measures, it was amazing the data that came out. So you could specifically target strategies that work. I think it's hard to blanket say we're going to do a really big one, but you can specifically target some things. I'm a big advocate of immunizations. Turns out that's also a bit of a nanny state thing, and I'm getting beat up pretty regularly in the legislature, but thank God Sarah Davis got reelected because she's been one of my champions, and if you live in her district, thank you for voting for her, even if you don't generally vote in that primary. She's awesome. We need to be fighting for things that science shows has results, and immunizations are one of the best ones that we have. So we've got to fight for those kind of things. But there are areas that you can measure, but this is kind of one of those depends answers. Those areas that we can measure, we need to identify it. I mean, what's the best thing to reduce hospital-acquired infections? We've known about it for 80 years. It's called washing your hands, right? But it took us almost 80 years to continuously improve the compliance of that. It's a simple intervention, and yet we know
I thought it was don't go to the hospital to start with.
So anyways, that's one of those interesting moments where you start talking about value and calculation and which areas can you specifically find areas that you can measure, but don't just broad brush it and say, well, everything we're going to apply to value base, and no matter what you come in for, to your point, humans are different, right? I mean, and not everybody responds to the same treatment, so it depends.
Yeah, but when you find one of those quality measures that actually isn't a quality measure, sometimes it's really hard to get away from it. And you look at, how many. No, I won't use that example because my wife says never talk about women's health issues. You're a guy, you can't possibly understand
don't
it.
go there.
I won't go there. So let me think of another pediatrics thing. How much difference does it really make for a kid that gets only 5 pediatric visits in their first year versus those that get 6? Right? We get penalized by not having at least 6 out of the 7 visits or something like that from the state. And it's like, I'm not sure we're making that much difference between 5 and 6 visits, and how much does that cost? But there's other services. Well, I can. This is a guy issue, right? How many stents are there out there, and that pretty good evidence now that wasn't a very good technology, and we back off of that. Because we do bring out the evidence, and that's saving money and not without hurting outcomes. So there's ways to do this, and it won't be perfect, and more of it will be process measures than real outcome measures. But the science is getting better and better all the time, including the science around comparative effectiveness, and that's the one thing that just drives me crazy. That as a society we have not, and you end up with people talking about death panels. These are people who want to save money and won't even allow us to talk about comparative effectiveness of different treatment or cost effectiveness. And it's like, if there's one thing that we should be doing a lot more around that, and it should be politically okay. I think I was trying to look, this is about information disclosure, about comparative effectiveness research, and it should be politically okay to do this because people do fundamentally understand that. Yet, for some reason, we've made it politically impossible to talk about comparative effectiveness of different treatment, and I don't understand why that's. I keep wanting there to be one on one slide and the other on the.
Because you're inching to rationing, right? I mean, we start talking about comparative effectiveness, it starts sounding a little bit like rationing.
It doesn't to me. I mean, we all ration ourselves every day we make decisions about whether or not it's worth it. Is the $3 hamburger or the $10 hamburger, right?
So I'm getting the signal, though, that I have to end things because we've hit 7 o'clock, although I see some of you still have questions. So hopefully our panelists, we can stick around for some of those questions. But let me just thank them all for what was a really fascinating discussion.